So this is a sputum cytology from a 60-something-year-old male. So the patient has been diagnosed with non-tuberculosis mycobacteria infection of the lung in the other hospital for about 1 year. So he has been treated as NTM for about 1 year. But the condition was on and off, and it's getting like worse recently. So he was transferred to our hospital. So through the admission, because the patient was impressed to have a typical infection of the lung, and this was his initial impression. And but there are some unusual finding of the patient's image study, so they do sputum cytology. So in our hospital, majority of the sputum cytology was sent to our chest medicine department, but they also sent the specimen to our department this time. So on low power, we see squamous cell epithelium. So these squamous cell epithelium were all coming from the oral cavity. So this is coming from saliva. So a good sputum cytology, we expect to see some alveolar macrophages, which means the specimen was coming from deep in the lung, in the respiratory tract. So here we do see some histiocytes. So seems like the specimen was quite okay because we do see some cells from the deep lung. So something unusual about this specimen that we see scatter very tight aggregates of three-dimensional structures. So it is like a scatter throughout the entire specimen. And some people would describe this finding as it seems to be like starry sky, like a just scatter like a dot, like a star in the sky. So this is one of the very typical pattern that in the old time we call this type of cancer that bronchoalveolar adenocarcinoma. So bronchoalveolar adenocarcinoma, nowadays nobody actually use this term anymore, but in the cytology world, this is a very typical finding of bronchoalveolar type of adenocarcinoma, that when the patient coughing, they show very scattered, like a starry sky type of pattern of the tumor cell in the sputum cytology. So if we do a TTF1, because normal pneumocyte won't be able to like coughing out in the sputum, so when we do a TTF1, we do see this like a very scattered, tight cluster, like a bright up like a sky, like a star in the sky. So this is very typical for bronchoalveolar type of adenocarcinoma. So actually, in the image study, it is actually between the differential diagnosis between whether this is a typical infection or this is bronchoalveolar type of adenocarcinoma. So after about 1 year, this is diagnostic. I think this is diagnostic for adenocarcinoma in the sputum, and the visiting of the patient was relatively junior. So I immediately make a call to her and ask her. Actually, the patient should do a liquid biopsy for at least EGFR testing to see if there is any drivers. Because when the patient was admitted, I think our chief resident was contacted whether they want to do an autopsy of this patient due to the typical infection. But this is actually a cancer patient. So I already told her, please don't do the autopsy. And yeah. So I just want to say that Because during our training in the medical school, we always there's always an old Chinese saying that we should taking care of our patient as our relative, like 视病有情. But how do you do that if you are a pathologist? If you only see the specimen, but you do not actually see the patient. But just think about if this is one of your relative who has been wrongly diagnosed in the other hospital, another teaching hospital for almost 1 year, and then come to our hospital and was already talk about the autopsy to the patient's relative that he might need an autopsy. But actually, this may be curable, at least like a controllable by nowadays the targeted therapy. That is something unfortunate, but as a pathology, and you know the clinician might not be able to manage the patient correctly, you would make a phone call to her. And after I called the attending, and they are a little bit senior attending from the chest department, call me to talk about these patients, and we both say, okay, we are old doctor, and when we see something like this, we will directly make a phone call to that younger, like a junior attending doctor to tell her you should do this. Yeah, otherwise they won't be able to manage the patient correctly, and the patient is going to expire without effective treatment. Okay, so the next specimen is 63-year-old female. So she came to our emergency department with abdominal fullness, and in our emergency department, she was identified to have massive ascites. So this is her ascites specimen. So on low power, we know that this is not a normal ascites specimen because we see tons of these tight aggregates of the cells. So the cells do show typical morphologic pattern of high-grade adenocarcinoma. So if you compare with the adjacent relatively normal cells, the tumor cells show enlarged nucleus. The nucleus is not perfectly rounded. You see a little notch over here, so this is quite irregular. And most of the tumor cells demonstrate prominent nucleoli. And the chromatin pattern is vesicular. So the tumor cell arrange a very tight three-dimensional cluster and with vacuolated cytoplasm. So in a middle age, like a postmenopause female with massive ascites, with this type of presentation, the first diagnosis would be this is most likely coming from either ovarian tumor, high-grade serous carcinoma, or primary peritoneal serous carcinoma. So because the patient was the new patient here in our ER department, and we need to better triage the patient. So the patient should be admitted to the gynecology department, not the GI department. So we will do a TTF1 immunohistochemistry on the cell block specimen. So then we have some aspiration specimen. There is one aspiration specimen coming from the bone. So in the aspiration specimen, there's almost no cells. So this is a direct smear. However, on the border of this direct smear, we see two clusters of high-grade adenocarcinoma, which has exactly the same morphology of the sputum that we see, of the ascites that we see. So this is floater, this is contamination. So when we interpret the specimen, we really need to be careful because we are working in a very large volume hospital, and it is sometimes if you see a specimen full of tumor cell like this is likely that the tumor cell will be shaded into the alcohol that used for the fixation of these slides and attaching to the other slide at the edges. So this has to be very careful because when you see this, you know this is adenocarcinoma, but this is not from the same patient. This is just a floater. So we really need to be careful. So when we prepare the specimen, our medical technician, if we prepare the specimen after the cytospin, if you see like a tiny granular, like a white dot on the slide, which means that it might contain a lot of tumor cells, and when after you do the smearing, it is ideal, if possible, you put the specimen in a separate fixation tank to avoid the potential contamination like this. So this is a contamination from the high-grade serous carcinoma, and the diagnosis of the slide was actually negative for malignancy. So we have some urine specimen. This is an instrumented urine. The patient have one specimen coming from the right ureter and the other specimen coming from the right renal pelvis. So this is the right ureter specimen. So for the ureter washing cytology, the cellularity is usually not as abundant as the renal pelvis because the space is much narrow in the ureter. However, on low power, we can see we do have a cluster of cells with very dark nucleus. And when we get high power of this field, you can see that the cells show a very high NC ratio and a quite hyperchromatic chromatin pattern. And just in this cluster, if it is a benign cluster, usually we will see some umbrella type of cell around this cluster. But in here, we do not see any maturation with umbrella cell differentiation. And this is throughout the entire specimen. So again, here we have some very tight cluster of cells. And if you take a look at the individual cells, these cells do show increased NC ratio and quite irregular nuclear membrane and hyperchromasia. So this is diagnostic for high-grade urothelial carcinoma. So for the same patient, this is a specimen coming from the renal pelvis. So here we see a lot of cells, just like we just discussed. And for this specimen, although there are some cells showing a little bit lower NC ratio, however, the nucleus was still very abnormal. And we can make a diagnosis of high-grade urothelial carcinoma. Just identify these higher NC ratio cells, much bigger nucleus compared to the inflammatory cell, hyperchromasia, and coarse chromatin. And this type of cell is throughout the entire specimen. So for the upper urinary tract high-grade urothelial carcinoma, it is very common to have multifocality along with renal pelvis and multiple lesions in the renal in the ureter, and this is all because that the carcinogenesis of urothelial carcinoma is had this phenomenon that we call field effect, because the entire urinary tract can be affected by the carcinogen, including cigarette or the other heavy metal or other chemicals. So this is very common to have multiple lesions. So for this patient, both renal pelvis cytology and the ureter cytology were positive for high-grade urothelial carcinoma. So the next specimen is a voided urine specimen. The patient is a patient of end-stage renal disease and receive a renal transplantation. So for the renal transplantation patient, in the voided urine specimen, we would like to see whether there were any virus inclusion cells. So these type of viral inclusion cells that we call decoy cells. And it looks a little bit like high-grade urothelial carcinoma because it seems to be quite dark in the nucleus and also with a high NC ratio. However, for this type of cell, you won't be able to see the granularity of the chromatin. So it is entirely smashed or ground glass, so compatible with viral inclusion in the nucleus. So this is a polyoma virus infection. And the infected cell, we call this decoy cell because it does show some feature resembling high-grade urothelial carcinoma, but this one is kind of typical. We call this comet cell, that the cell have a big nucleus, but with a cytoplasmic tail, looks like a comet, 像彗星一样. So this is a comet cell and with a ground glass nucleus, so this is positive for virus infection. So for this type of virus infection, it is most likely due to the immunosuppression by the control of the transplantation's rejection. So when we see this type of virus, the clinician would need to adjust the dosage of the immunosuppressant. Otherwise, there might be a graft failure, which means the transplant kidney might be damaged and without any function. So next, we have EUS guided biopsy for pancreas. So this is a 58-year-old male, and this is performed through the stomach. So on low power, we do see some relatively benign-looking mucosal cells. So this looks like gastric foveolar cells because all the cells do show a mucinous cap on a different level, and this is a nice organized honeycombing arrangement. So this is coming from the gastric foveolar mucosa. And then we do see some necrotic debris in the background. So we start to see some relatively irregular glandular cluster, and you can appreciate that this is a big nucleus and this is small nucleus. The distance between the nucleus is uneven. So in this liquid biopsy specimen, we have mostly necrotic debris, and the tumor cell is kind of overlapping with each other. But this is another example. Just in this glandular cluster, you can see there is a very, very big nucleus. And in the same cluster, there are much smaller nucleus. So this gap, this difference is about 1 to 4 times bigger. And this is what we use for one of the diagnostic criteria for adenocarcinoma of the pancreas, remarked polymorphism, difference between the nucleus. So this is positive for adenocarcinoma. So another pancreas specimen. So for this specimen, we also see some stromal component with a very complex collagen deposition. So this is what we consider desmoplastic stroma, which is most commonly induced by the invasive adenocarcinoma. So then we do see this tight cluster of the cells showing relatively irregular arrangement as well as nuclear polymorphism. So this is also positive for adenocarcinoma. So occasionally we will receive EUS guided aspiration specimen for non-neoplastic cause. So for this patient, this is a 53-year-old male, and this is transduodenal aspiration. So you can see scattered goblet cell here and there. This is duodenal mucosa, not the gastric mucosa. So for this specimen, in the background, we see a lot of these like a crashed inflammatory cells. And these are dissociated gastric acinar cells. So a lot of inflammatory cells, benign-looking mucosal cells, and we do not see any a typical cell looks like the adenocarcinoma that we just saw. So when I checked the patient, he already received the blood testing for IgG4, and the IgG4 is highly elevated. So the patient is actually a patient of IgG4 related autoimmune pancreatitis. And in this specimen, we only see benign mucosa, we only see benign acinar cells, and along with quite prominent inflammatory cells in the background. So we will call this negative specimen, and the biopsy specimen, they will also do IgG4 testing to check whether there were any increased number of IgG4 positive plasma cell. So the specimen is negative. Okay, that's for all the case today. Thank you.